Welcome, everybody, and thank you for joining us today for our TIF Talk Tuesday. We are very excited to have our special guest, Dr. Aman Ali. Thank you for being here, Dr. Ali.
Pleasure to be here.
Thank you. So let me give you a little background on Dr. Ali. He is a graduate of Kind Edward Medical University in Lahore, Pakistan. He completed his internal medicine residency training at the Cleveland Clinic Foundation and his Gastroenterology and Hepatology Fellowship at Lenox Hill Hospital in New York. Dr. Ali finished his Advanced Gastrointestinal Therapeutics and Interventional Endoscopy Fellowship at Harvard Medical School in Massachusetts General Hospital and Brigham and Women's Hospital in Boston. Dr. Ali practices gastroenterology at Gateway Surgery Center and Digestive Care Associates in Kingston as part of Covenant Physician Partners. He is also the Director of Advanced Endoscopy at Wilkes-Barre, Pennsylvania. So again, Dr. Ali, thank you so much for being here tonight.
It's a great pleasure to be here.
Fantastic. Thank you. So as a reminder to everybody that is watching for our TIF Talk, this is a live event. At any time, if you have any questions, please feel free to type it into the comment section on Facebook, and we will do our best to answer all of your questions this evening. So again, we'll go ahead and start. Thank you, Dr. Ali, for being here. We're going to talk about GERD and the TIF procedure. So I'll let you kind of start off telling us a little bit more. What is GERD, or chronic acid reflux?
So GERD is this is an acronym which stands for gastroesophageal reflux disease. So G is gastro, esophageal is esophagus, reflux is regurgitation or backward motion, and a disease. So gastroesophageal reflux disease is a disease, as you could see in the name of this condition. It is not just an ordinary reflux or heartburn. There's a lot of terminology that's thrown around loosely. People get a little indigestion occasionally after eating spicy or greasy meal, or if they get stomach upset, if you will. These things are occasional, and pretty much anybody can have some of these symptoms occasionally. However, gastroesophageal reflux disease is a pathological condition. It's an abnormality. It's an ongoing illness that is defined by abnormal regurgitation or reflux of contents of stomach, whether they're acidic or not. And that produces symptoms, in effect, affecting the quality of the life of a patient. So gastroesophageal reflux disease is not necessarily an occasional heartburn or indigestion. It is an actual disease entity.
Yeah, thank you for that. And you had mentioned it's a pathological disease, right? It's I think a lot of patients get confused and think it's, I just produce too much acid. So it's almost a nomenclature thinking that that's the situation for GERD. So let's talk a little bit about what are the things that you tell your patients to do to kind of initially manage their GERD symptoms.
So first, as I mentioned, that you have to make a correct and appropriate diagnosis. A lot of patients who think that they have excessive amount of acidity or they produce too much acid, as you just mentioned, that's a misnomer or misconception. There are some hypersecretory conditions where patients do in fact make excessive amount of acid, but these conditions are excruciatingly rare. There are some conditions, as I said, they're very, very rare. And as we're getting trained in our residency and fellowship, we learn about these things. But practically in our day-to-day GI practice, we seldom see these. So these are conditions when acid is produced in excessive amounts, and you have to use what we call anti-secretory treatment or PPI and other medications to really curb the amount of acid. The routine majority of the gastroesophageal reflux disease that patients that we see, they are not necessarily excessive acid producers. They have normal to a high normal, or even sometimes slightly more, higher than normal amount of acid, but the barrier that prevents the acid in the esophagus, at the lower end of the esophagus, that is broken. There is a mechanical defect there. The valve, which prevents the contents of the stomach and acid and non-acid secretions such as bile and other things, that valve is supposed to prevent them from coming back up into the esophagus. And you see, the esophagus is just a pipe, which is a conduit, essentially meant to carry the food from the mouth through the chest into the stomach, in the gastric area where it belongs. But once the food is in there, it's mixing with the acid, bile, and other secretions for appropriate digestion. And occasional little regurgitation will happen subclinically or asymptomatically, and you would not even feel it, or feel it very occasional, and that's okay. That's normal, that's physiological. But if the barrier at the lower end of esophagus, the sphincter or the valve, if you will, at the lower esophageal sphincter, it does not function properly, then the mechanical defect allows all the contents of the stomach, regardless of what they are, to regurgitate back upwards in the esophagus. And esophagus itself is not designed to sustain the acid exposure. And the nerve fibers there feel the chemical change and the acid and the inflammation that occurs as a result of it. That also is felt by the patients. Not always, but some patients feel it. And then hence the entity of gastroesophageal reflux disease comes into play. So you have to identify, going back to your question, the patients truly have an ongoing chronic condition that is defined by some as having at least 3 or 4 episodes of acid reflux in a week that requires either over-the-counter treatment or prescribed treatment to control the symptoms to function properly. And that does affect the quality of their life. If I determine these kind of symptoms happening on an ongoing basis, then I make the diagnosis of GERD clinically just by talking to the patient.
Yeah, I really like that personalized approach that you're talking about. For every patient, it's different. So that's really great. Are there things that patients can do? You slightly mentioned about taking some over-the-counter, PPIs or medication, and or potential. Are there things that they can do? Diet, changing their diet, physically. We hear doctors talking about raising their bed when they're going to sleep. What are kind of some typical things that you recommend them to do at the beginning when they're just kind of first diagnosed with GERD symptoms?
So it's just the nature of our practice that we see the patients who are not your average patients who will walk into their family doctor or primary care doctor's office. And the question you asked is relevant and pertains more to that first line of contact with the healthcare provider. We usually see the patients on a sort of tail end of things or in somewhere in the middle where they have tried a number of things and eventually then they see a specialist to further assess the situation. But going back to the index or contact or the original contact with the healthcare provider, when you have somebody with chronic GERD symptoms and they come to you, I don't just reach out for my prescription pad immediately. I would actually talk to them about the disease, about the natural history, the course of the disease, and the lifestyle modifications are the number one things that you want to do. Now, those do include not eating very late. and going right to bed, because as I said, the valve at the lower end of the esophagus, if it's not functioning properly, if you eat a particularly heavy meal with high fat content or some spicy foods, chocolate, mint, there's many other food elements that they can sometime affect patients negatively. A lot of people tell me red sauce or tomato-based or citrus-based foods will cause problems for them. If they have inciting foods and they're taking them towards the end of the day and then going right to bed after that, that's setting up for a problem, you know. So we talk about that. We talk about, in my experience and in my practice, I always encourage them after dinner, especially in a summer weather, I will ask them to go out and have a walk. Because as you increase the physical activity, you do accelerate your digestion. There's peristaltic waves in your stomach and in your intestine. They are triggered more as you are more active. That is a very good advice, which is good for their otherwise heart health anyway, but also for the digestive system as well. I also talk about avoiding the trigger foods, particularly at the time where the lower esophageal sphincter will be at risk for refluxing, such as nighttime. And that does, as I mentioned, include chocolate and mint and greasy and oily foods and any high fat content, alcohol. These things will cause problems. So maybe, just giving at least 3 to 4 hours after the dinner time before going to bed, and then some kind of exercise or gentle activity at that time helps prevent some of these things. Now, when you go to the bedtime, at that point, midnight snack is discouraged. I would say it's not a good idea. A lot of times there's something sweet that you had your eye on all day in the fridge, and that's calling your name, and you go to the fridge. I would discourage that. And I would also say that as you're sleeping, at that point, you have to be mindful of certain things. And one of the things a lot of docs will talk about, and what we learn as we're learning about this disease, is to somehow either find a wedged pillow, or have an extra pillow, or if you have an ability to put a wooden block or a brick or something at the head end of the bed to elevate it a little bit. Now there's some of the newer beds are available with that recline function, and that can help as well. And just the way the anatomy works, if patients sleep on their left side, if they're reading a book or something, and if they intend to sleep on their left side, on their left shoulder, that is much more beneficial in terms of GERD. Because as the esophagus dips down into the chest, it takes a left turn. And the stomach is sitting on the gravity side. So gravity is helpful to you, and the reflux going backwards is discouraged if you're in this position. So at least you can start out that way. You don't know what's going to happen when you sleep. I mean, you can be all sorts of position, but at least initially you could try to make a conscious effort to do that. So these things can help. And then last but not least, the way the sphincter works and the diaphragm works, where this connection between the stomach and esophagus is, if there's a lot of pressure on the diaphragm from the abdominal cavity and from the visceral fat, if you are overweight or your BMI is up, if there's elevation of the pressure exerted on the diaphragm, you will have more GERD no matter what. Even as little as 5 to 10 pounds of weight loss can make a huge difference in dose de-escalation for patients who are already on medications, and even make them come off the medications if they're on very mild amount of medicine. So that definitely helps.
There was a lot of pearls of wisdom in everything that you just explained that I think a lot of patients don't know about. So thank you for sharing that. We have a lot of questions that have come through. So let me, I did want to talk, and you did mention, Generally, you can go to your general practitioner or your FPGP, and they'll kind of initially say, take this PPIs. We can talk a little bit about PPIs, but when they come to see you, and I think that's a big question these patients have, is when do I see a specialist about this? Because that's what you guys do. And so let's talk a little bit about that. And then one question that I saw pop up was what type of testing is done prior to having the TIF procedure. So if you can talk a little bit about that, that would be fantastic.
So as I mentioned earlier, Andrea, it's a very individual patient care. You have some patients who will do just the lifestyle modifications and they feel so much better. They go through some components of testing and everything checks out, and there's no further escalation of investigations or any other testing is needed, and that's great. Sometimes less is better. But then we're talking about the patients that we see as specialists, if these simple lifestyle modifications and a short course of medication by your GP takes away the problem symptomatically, and more importantly, if you feel better on the regimen and your quality of life goes back to normal, and if you're lost some weight and you're eating healthier and you're following those lifestyle modifications and you're doing just great, that's wonderful. There's only one caveat with that. There are some patients in that category that they feel really good after having a short course of medication by their family doctor, and they feel good afterwards, and they're following all the good lifestyle modifications. They still need an evaluation by a specialist for the preventative reasons. Just like a lot of people will go for colonoscopy when they turn 50, just for prevention, or people go for mammograms or pap smears and so forth for preventative health, for cancer screenings. Similarly, there are criteria outlined that if you have chronic acid reflux, and even if it is controlled on very minimal medication or just lifestyle modification, but is a clear-cut gastroesophageal reflux disease diagnosis, if you are that patient and you have some risk factors for a condition called Barrett's esophagus, then no matter how good your control is, you should still have an endoscopy evaluation done to screen for Barrett's, because regardless of your symptoms, that could be present, and if present, that does need to be monitored over time and treated if some dangerous features develop in Barrett's, because esophageal cancer in my practice has been always a silent cancer and sometimes a silent killer. And patients who have GERD, they at times have very minimal symptoms, but if they have those danger red flag signs, even though their GERD is very well controlled, they should still see a specialist. Their family doctor should make that referral, or they should ask their family doctor for the referral. So the things that pop up immediately, if you have even if you have mild GERD or worse, severe GERD, if you are male is more high risk than females. Not that females don't develop Barrett's, but male is higher. If you're above 45 years of age, and if you have chronic gastroesophageal reflux disease, a proper diagnosis of it, and particularly Caucasian race, these things will be considered very clear-cut indications for screening for Barrett's esophagus with endoscopy. But the patients who have not only these things, but also have a family history of esophageal cancer, or if the BMI is elevated or obesity is there, these people should also have a consideration, although they are not clearly in the guidelines, but clinical judgment prevails there. So that's the caveat for otherwise well-controlled GERD patients still for screening. And important point to mention here is that GERD has a disconnect of symptoms. And what I mean by disconnect is I have seen the patients who are complaining of absolutely horrendous reflux, and it's affecting their quality of life severely. But when we do the endoscopy, which we'll talk about in testing in a few minutes, we will see their esophagus looks fine. There's no ulcers, there's no bleeding, there's no Barrett's esophagus. And had you not told me about how severe their GERD was, I would have called it a normal esophagus because it is normal. It looks normal endoscopically. And on the flip side, there's a spectrum of patients who absolutely have no GERD symptoms or very minimal. And they'll say, hey, doc, I'll have a little bit of a heartburn here there if I ate something wrong. And you go in there and you see their esophagus and there's a war zone in there. There's ulcers, there's bleeding, there's strictures or narrowings of the esophagus, there's Barrett's esophagus, even precancerous changes. So there's a disconnect going on here. So the screening of Barrett's is all about what patient population you're dealing with, and if they're Caucasian, male, obese, above 45 with the chronic GERD, no matter how good their symptoms are, you still need to screen for them. Now come with that very important message for the patient. Let's moving on to the Gerd workup.
Yeah.
So when patients have any of those things, they should ask their family doctor to refer them for a specialist. But also, majority of the patients who have tried some of the medication that family care doctor has prescribed, or they have picked over-the-counter medicines themselves and they've given it a shot and still have a lot of symptoms. And or they do get better when they stop taking medication, symptoms come back, and then they're medication dependent. All these patients should be seeing a specialist for further evaluation, because not only for their symptomatic condition, but also for screening for precancerous situation, and also to assess what the problem is that needs to be fixed further or not. And that's where we come into play. So we'll have a consultation, and there's a variety of different tests that we have at our disposal. The initial test should be the endoscopy, upper GI series, or esophagram, or barium, or gastrographin esophagram, which are the x-rays where they swallow white chalky material, and then the x-rays are taken. They are fine as well. In some patients, you need both of them. And then after the endoscopy, we see if there is a mechanical problem. There's a diaphragmatic hiatus, the opening of the diaphragm, if it's too loose. And if the stomach is sort of herniating back and forth in that area of the lower esophagus, from the stomach into the chest. And if they have that mechanical defect, then we diagnose it correctly and we stage it to which kind of a stage this hiatal hernia is in. And at that point, you give them a course of anti-secretory medications, because these are powerful medications. I'm not here to bash the PPI or proton pump inhibitors, such as you have a variety of them like Prilosec, omeprazole, Nexium, pantoprazole, lansoprazole. These are all same class of medications. I'm not here to necessarily just focus on the negative. These medications have tremendous value in certain patients. And going back to 30 years ago, when majority of the general surgery operation done by routine regular surgeons were gastrectomies. The patients were having their stomach removed before the PPI era. So these medications have made a tremendous positive impact if you look back at that way. But having said that, these medications also have a potential for being abused when you go to a busy family care doctor and he has 7 or 8 other different things he has to address, and one of them is GERD. It may be much easier for him to reach out for prescription pad and say, okay, just take Nexium and I'll see me in 3 months and see what happens.
Yeah.
So there's a potential for not necessarily abuse, but overuse of these medication, and then there's no stop date. You take them, and then what's next? The problem is still there, defect is still there, hernia is still there. 3 months later or 6 months later, things are going to come back. So we do investigate these people, and then after initial treatment and trial, we follow up to reassess the patient after the initial PPI treatment and see if the patients who have persistent problems. Then the second stage of testing is warranted.
Perfect. Thank you. So we have a question from Liz. She's asking, what are the natural methods to treat acid reflux?
Okay, so it's funny that I was just talking just today to one of our nurses about this. Before the PPI, people were taking a sodium bicarb or like baking powder and things like that. They were drinking milk, and there was a condition that we learned about in books. It's called milk Oakley syndrome, where basically people would drink too much antacids and milk products just to neutralize their acid to make feel better for temporarily. So I have had a lot of patients who will swear by a certain herb or the other that they are taking, and that helps them feel better. But if you really talk to them carefully and listen to their story, you'll realize that patients are doing all the other lifestyle modification we just talked about. And then that one herb that they think is the magical herb or supplement that's taking care of all of their symptoms is just their belief in it, or their placebo effect is happening from them. But the real issue is that they've taken good care of themselves, and they're healthier, and they're eating right, and they're following all the good lifestyle modification things. And in this day and age, we have a lot of information available on the internet, and people are smart, and they go up and look up stuff, and they see what needs to be done, at least in the initial stages. So that's wonderful. But as far as the natural regimen, and by natural we means usually the herbs and supplements, I have it. I'll exercise caution there, because these are labeled, even though the herbs and supplements is a multi-billion-dollar industry. You will look at every label, and it will say this is a food supplement, and it's not FDA approved, because there's no standardization, and you don't know one bottle to the other what exactly is in there and what quantity is in there. And all the health benefits which are proclaimed by the different companies making these drugs are not tested and verified. So unfortunately, I hate to disappoint you, Liz, but there isn't a magical herb to treat it.
Thank you for that. We have another question, and you can probably talk a little bit more about this. This is Andrew. He's asking, how important is it for me to have my hiatal hernia fixed?
So not every hiatal hernia needs to be fixed. You have to go back to the overall patient's health, and all these investigations and the symptoms and the testing that we're doing. These are all small pieces of puzzle, and you have to put them all together to come up with a firm recommendation about what the next step for their care is. So that's one thing. But if you have a hiatal hernia along with the severe chronic medication-dependent acid reflux, now that's a different animal. And depending on what kind of a hernia it is, and what grade of severity of the hernia it is, there's different options available for that. So one such option is a TIF procedure, especially for small hiatal hernias when it's very small defect, and just by doing the endoscopic suturing and augmentation of the sphincter, you will be able to reduce the hernia as well in the lower end of the esophagus. So that is one option, a minimally invasive or ultra minimally invasive option for the hernia if you have symptoms from it and it affects your quality of life. Other surgical options for doing a pure surgical procedure, laparoscopically or robotically, those options are also there. But in this day and age, we try to reserve these for much more severe grades of hernia or with some other anatomical considerations.
Perfect, thank you. You touched a little bit about the TIF procedure as perfect segue. Why don't you talk a little bit about the mechanical, how does the TIF procedure work?
So a TIF procedure is a transoral incision-less fundoplication. So transoral is self-explanatory, so we're going through the mouth. And incision-less is also explains that we're not doing any incisions just for the TIF part of the procedure. Sometimes we do it combined with a surgeon, where they make very small incisions in the stomach, such as having your gallbladder taken out, just a small laparoscopic port incisions. So not a big operation either way. But for pure TIF procedure, we go through the mouth, it's incisionless, and it causes a fundoplication. Fundus is the very top part of the stomach, or the roof of the stomach, if you will. And fundus is the area which is somewhat loose and has some compliance and ability to contract and relax. And in matter of fact, this is the area where food sort of kind of gives the signal to the brain from this area to stop eating. So when fundus gets distended after we feel, the sensation of fullness, then we stop eating. So it's a very compliant organ and has the ability to relax and contract. But fundus also has this ability, portion of the stomach has this ability to be used for the fundoplication. Plication is just kind of suturing. So we use part of the fundus of the stomach endoscopically and wrap it around the lower esophageal sphincter area, which is weak. So we use your own body's tissue and sort of use it as a wrap to make the sphincter stronger. And the way this procedure is done is endoscopically, but as I said, some patients will need a combined procedure because the hiatus or opening of the diaphragm is a little too big to be just fixed with the fundoplication. So you will have to have a surgeon perform a laparoscopic procedure where they will put those sutures on the hiatus or the opening of the diaphragm, again with a very minimally invasive approach, with the incision through the belly button and through one or two ports in the skin, and they will close that hole, if you will, in the diaphragm, which got too loose over time. And then after that, we do the TIF procedure to make the sphincter augmented like it was originally meant to be.
Perfect. Thank you for that. We have a comment from Cheryl. She's saying, hello, swallowing is hurting, feeling something stuck in my throat, but she doesn't taste acid. Is that pretty common?
Not every GERD patient will have just a classical heartburn symptoms. As I said, alluded to earlier, some patients will very bad damage to the esophagus, even precancerous changes, will have no symptoms. They feel, because we are wired differently, the nerves perceive differently in all patients. So not all patients are the same. I have some patients who have legitimate GERD, but they have, the only symptom they have is the hoarseness of voice. If they can't sing in the church anymore, their voice is changing, or it's hoarse all the time. They've seen the ear, nose, throat physician, and they tell them it's GERD because it's all red inside their voice box or larynx. I have some patients who would not stop coughing at nighttime. When they take the Nexium or Prilosec, their coughing decreases. And then by appropriate testing, we have to touch a little bit upon second level testing, but we do the pH study or acid study to see how much acid they're producing. And we in fact diagnose that their chronic cough is coming from the GERD. I have a lot of patients who will complain of difficulty swallowing. And when they eat bread or chicken or some tough to chew meat like steak or something, and they feel like it's just sticking as it goes down your esophagus. And matter of fact, that is a classical symptom for GERD. They don't have heartburn, they don't have acid reflux, they don't have burning sensation in a common terminology, but that difficulty swallowing is their GERD. That's how they're manifesting. And what happens is there are ulcerations and inflammation in the esophagus from silent GERD, and that's causing stricture or narrowing in the esophagus. So mechanically, the area of the esophagus gets narrow, and that's how they're presented. And we see this all the time.
Yeah, perfect. So a couple of other questions. Let's see. So Matthew says that he's concerned about all of the bad press about PPIs that he's heard about in the last several years. Would TIF allow me to get off these daily medications?
So I just have a realistic expectations with my patients, and learning from your patients are the best educators for you. So they teach you how their symptoms are before and after procedure, before and after intervention, medications, and a lot of time what you know medically and scientifically. In the real world practice, patients are some of the best educators in the way. So the way I approach this subject with my patients is that we will be definitely decreasing the amount of medication they need. And if I'm able to get them off the medication or get it down to the lowest dose possible, even that is a success. But talking to these patients afterwards, after the TIF procedure or any other anti-reflux procedure, what I notice is that their quality of life is significantly better. You don't know how bad you have it till you don't. And then you reflect back on the time when you were suffering from it on a daily basis. And then you say, wait a second, my only regret is I should have done this sooner. But having said that, I noticed in our experience that patients' requirement for these medications, PPI or otherwise, does go down. And in quite a number of cases, we're able to take them off the medication altogether or prescribe them something, not as strong and still get their quality of life better with their symptom control.
Okay. Thank you. So 2 questions. Is TIF an effective solution? This is from Chris. Is TIF an effective solution to LPR? And then also, does it work with poor motility?
So the 2 different questions. So LPR is a term which is used basically for the reflux that is up here in the larynx, in the laryngopharyngeal reflux, LPR. And larynx is your voice box, pharynx is the back of your throat, and reflux is reflux. So when the reflux in some patients is so bad that it travels all the way up from the chest into the back of your throat, causing the irritation of the voice box, and even silently going into your windpipe or trachea in the nighttime and causing microaspirations and coughing spells. That's a scary situation. A lot of these patients wake up gasping for air, feeling like they're having a choking spell. Even they will say something like, I choked on my own saliva, but this is actually the reflux of acid. And acid is very powerful. So if you happen to spill that acid on your skin, it will burn. So imagine that burning in the back of throat, in the lungs, or in the voice box. And your voice is very weak and hoarse in the morning, and they feel that sensation of sore throat, like they can never clear their throat completely because there's something there. They feel that all the time. So just because we're fixing the barrier at the diaphragm, at the hiatus of diaphragm, that is a great thing, that not only is preventing the reflux into the esophagus, but if the reflux originally was so bad that it was going back up into the back of throat and causing LPR, it will be an effective solution for that as well.
Perfect.
So this, having said that, I don't start doing TIF procedure on anybody who has chronic cough. I have to know for sure that that's coming from acid reflux. And that's a good point to mention. One of the tests that is very important in my practice is we do the pH study. Or Bravo pH capsule implantation. This is a microchip we insert in the esophagus, and patients off the medication usually for this procedure for about 1 week. So we test them in their natural state when they're producing normal amount of acids. And the beauty of this procedure is that they don't have any tubes or catheter coming out of their nose. It's all wireless, and the capsule or the microchip that we insert in the esophagus will go transmit the data wirelessly, like a Bluetooth, if you will, to the recording device that they carry. So it's an acid reflux monitor they're wearing for 48 hours. And after we get those results, we know the gravity of the situation, how bad the reflux is. And more importantly, during those 48 hours, if they had symptoms such as cough or hoarseness of voice got worse, or they had heartburn, or they had any of those reflux-related or regurgitation-related symptoms, they push those corresponding buttons on the recorder. So we can have a symptom correlation with those symptoms. Not only we quantify over the 48 hours if they have pathological GERD, but we also have symptom association probability, which is the scientific way of knowing for sure that these extraesophageal symptoms are truly coming from GERD. And some of the common ones are the cough and the hoarseness of voice.
Yeah. And then the other part of that question, does it work with motility, poor motility?
So that is a little bit complex question without getting in too technical with it.
Sure.
I would say if it's a pure motility disorder, that we know that the motility disorders are the disorders for how the esophagus moves, or the peristaltic wave is the contraction of muscle and relaxation that goes through the esophagus. If it's a pure motility disorder, the motion of the esophagus or neuromuscular connections of the esophagus are abnormal. And we have a variety of different motility disorders. If it's one of those, then TIF is not the procedure for that. Or any anti-reflux procedure is not the procedure. In matter of fact, it's relatively contraindicated to do these procedures in that patients because you are actually making a lot of time these motility disorders will have tight lower esophageal junction, and you're making it even more tighter to make it difficult for patients to swallow. But having said that, you have to not disregard completely the motility disorder being treated. If you still believe that GERD is the major player based on the testing and symptoms of the patient and your assessment, and motility disorder is sort of lurking in the background, but it's not the predominant player, then you could modify your approach in treating that patient, and you're convinced that majority of their symptoms are coming from GERD, you will still perform the TIF procedure on them. And the beauty of the TIF is that it's not a 360-degree wrap around the lower end of esophagus. So you're not making it super tight. They still have ability to burp and belch, and the food goes down with no difficulty after the TIF procedure, like it's supposed to be. So, and the other thing is that motility studies will sometimes say non-specific motility disorder. That's how the label comes out when the report comes out after esophageal manometry, which is the study to do the motility testing of esophagus. You have to be careful interpreting that non-specific motility disorder label, because a lot of GERD patients will have that. So that necessarily doesn't mean that's the driving force. That is just an association of GERD, and GERD still needs to be treated.
Yeah, thank you. So someone's asking, Corlene's asking, please talk about the recoup time after the TIF, example, diet. So I knew this would come up. So can you talk a little bit about what patients could expect, kind of day of the procedure, how long do they stay in the hospital? And then specifically talk about, post-op, what do they need to do after they have the TIF procedure?
So I talk to my patients about the procedure depending on whether they're having a primary TIF procedure where no surgery is involved whatsoever, or if they are having a combined procedure where they will have a laparoscopic hernia repair, and then I will do the TIF procedure endoscopically in the same setting. They will typically will stay, first of all, they come in, they are not eating or drinking anything by mouth after midnight the day before the procedure. And I, in my practice, will have them on some anti-nausea, strong anti-nausea medicines. I will even have them put some motion sickness patches behind their ears in anticipation for the procedure, because I want my patients to be comfortable after the procedure, have no nausea, and they should not be retching and causing that just newly operated on area to be affected negatively in any way or shape. They also are given medications to have them more comfortable post-operatively ahead of time. So their prescriptions are all given by my office ahead of time. They're already filled in. They're medications to help soothe the esophagus, numb the area a little bit for discomfort, and antacid properties and so forth. Because remember, the anti-reflux part of this procedure, healing still takes place over the course of next couple of months. So you do have to still be on the same medications that you've been on, with the idea that eventually will get you off those medicines. Then the procedure itself takes place, and post-operative period, again, our protocol in the hospital, the nurses, the nurse anesthetist, the anesthesiologist, the post-op recovery nurses, they're all very well versed with this, that nausea is of extreme importance to be controlled, and the medications for pain are given to the patient as well to keep them comfortable. And I keep them hydrated, so they'll have a IV fluids going overnight. We keep them overnight in the hospital, just again as a precaution. Some patients potentially can go home, but and a lot of them, they would ask me, why are you keeping me? I feel great, but I feel it's a good idea to stay overnight, at least for 23 hours. We call it 23-hour observation in the hospital. The next day, we typically do a upper GI series. This is an X-ray we perform, again, to see not only how well we did with the TIF procedure and the Heidel hernia repair, but also to make sure there's no subclinical or subtle leak or anything unexpected that we don't want to see in the first post-op day. Then they're given some very strict instructions for the post-op diet. That does include liquid diet, and we slowly escalate. Each day is spelled out exactly what foods you can eat and not eat, and you guys have done a great job at Endogastric Solutions for the patient help pamphlets. So they have day by day exactly spelled out how they can have what foods at what stage. Generally speaking, over about 4 to 6 weeks period of time, they're back to their normal day-to-day routine foods that they were taking before. I do caution about lifting weights and rigorous exercise in the immediate post-operative period for at least 2 weeks. Anything above 5 or 10 pounds, even I would not want to exert too much pressure on the diaphragm to have those sutures be in more relaxed phase initially. And other than that, in my experience, a lot of my patients have gone back to work within a couple of days. They take, as a precaution, they take 1 or 2 days off from work, and if they have a weekend come in, that's great. And then they're back on their feet after a couple of days back to work.
Perfect. Thank you very much. So we got a last question here. Where is he located? So maybe you can, I know we said at the beginning, but just remind everybody that's watching where you are located.
So I do practice in Kingston at Gateway Surgery Center and Digestive Care Associates as a part of Covenant Physician Partners. So that's our office. Outpatient evaluations and office visits happen there. Then the TIF procedures and all the other complex endoscopy procedures that I perform, they happen at the Wilkes-Barre General Hospital, and that's in Wilkes-Barre. So yeah, that's where we perform these procedures.
Perfect. Thank you. Well, we've come to the end. There's a couple of other questions, but I feel like we've maybe answered most of them throughout your talk. It was very informative, Dr. Ali. We can't thank you enough for joining us tonight. Any last bits of advice that you would give anyone that's suffering from GERD or chronic acid reflux?
My advice would be that be an advocate for your health and for your loved ones. And when you do go to your family doctors or primary care doctors, they are doing a fantastic job taking care of a lot of other health issues that patients do have. And I feel GERD has been thrown in the back burner, if you will. Heart disease, diabetes, other issues have been more on the minds due to the disease burden that's out there, and those are very important to address. But when it comes to GERD, I think the awareness is important, and knowing that the options are there to help you out, and some of these medications that can be detrimental for you if you take them for a long period of time. And one of the problems with these medicines is, for example, bone fractures or osteoporosis and things like that. That doesn't happen overnight. So therefore, cause and effect association sometimes is missed. If somebody who is 42-year-old and she comes to me for GERD evaluation, and if I put them on Nexium or Prilosec for 30 years, and if they develop a fracture at 75, and then everybody wonders why that happened. Well, it could have been avoided if we did something right 3 decades ago. So these things, so awareness is important, talking to your family doctor and being your advocate for, okay, what the next step I can do, what can I do further, will be important. And just learning about your conditions and be more proactive and research it and ask.
That was great advice. Thank you so much, Dr. Ali. And everyone that is watching tonight, please know if you're in the Pennsylvania area, you can find Dr. Ali. If you're not, you can go to our website, gerdhelp.com. There is a physician finder on there, and you can type in your zip code or state, and you'll be able to find a TIF-trained physician in your area. Again, Dr. Ali, thank you so much for joining us this evening. We appreciate your insight. And for everybody else watching, please feel free to catch us next time, next Tuesday for our next TIF Talk. So thank you, everybody. Please stay safe and warm. Have a great evening, and we'll catch you next time. Thank you very much.
Thank you, everyone.